Table 12.6 Management of low urine output. Ensure that follow catheter is in the bladder and is patent. Optimize cardiac function. Treat hypokalemia, control arrhythmias, improve contractility, reduce elevated afterload, but allow blood pressure to drift up to 150 mm mercury. Diuretics or other medications. Give increasing doses of furosemide up to 500 mg IV or a continuous infusion of 10 to 20 mg hour. Add chlorothiazide 500 mg IV to the loop diuretic. Consider bumetanide 4 to 10 mg or 1 mg bolus, then 0.5 to 2 mg hour infusion. Give cocktail of furosemide, dopamine, mannitol. Consider use of nisiritidine 2 nanogram kilogram over 1 minute followed by an infusion of 0.01 0.03 nanogram kilogram minute if elevated filling pressures. Consider use of phenol-dopam 0.1 nanogram kilogram minute, especially if hypertensive. If above fail, limit fluid to insensible losses. Readjust drug doses. Avoid potassium supplements. Nutrition: essential amino acid diet. High nitrogen tube feeds if on dialysis. Total parenteral nutrition with 4.25 amino acid, 35% dextrose. Consider early renal replacement therapy. Optimize preload without being overzealous. Hemodynamic monitoring with a Swan-Ganz catheter may be indicative if a low cardiac output state is suspected. If the diagnosis is not clear, echocardiography can differentiate ventricular failure from tamponade from significant hypervolemia. Otherwise, assessment of fluid balance, central venous pressure monitoring, strict intake outtakes, and careful physical examination may give an overall assessment of the patient's fluid balance and intravascular volume. Remember that in a state of capillary leak, often seen in sepsis, following surgery with a long duration of cardiopulmonary bypass, or with a persistent low output state, or with reduced oncotic pressure as noted from hemodulation or poor nutritional condition, excessive fluid administration may produce non-cardiogenic pulmonary edema. Optimize heart rate and treat arrhythmias. Even though the patient may have a satisfactory heart rate, increasing the rate with pacing to augment the cardiac output might prove beneficial in improving renal perfusion and glomerular filtration rate. Improve contractility with inotropes if a low cardiac output state is present. Reduce afterload with vasodilators and try to eliminate drugs that can cause renal vasoconstriction. Avoid ACE inhibitors and angiotensin receptor blockers. Don't be overly aggressive in the reduction of systemic blood pressure in patients with pre-existing hypertension and chronic kidney disease. They usually require a higher blood pressure, 130-150 mm mercury systolic, to maintain renal perfusion. If inotropic drugs with vasodilation properties are used, such as milrinone or dobutamine, an alpha agent may be necessary to maintain systemic blood pressure. In this situation, norepinephrine is the preferred drug because it will also provide some inotropic support. Use of a poor alpha agent such as phenylephrine is more likely to cause renal constriction unless the cardiac output is excellent. Vasopressin should only be used in vasodilated states with good cardiac output. If the cardiac output remains marginal, despite the use of multiple inotropes, consider placement of an intra-aortic balloon pump. This may result in an abrupt and dramatic increase in urine output. If Oliguria persists despite optimization of hemodynamics, the next step is selection of a diuretic. Also, a few studies suggest that loop diuretics may hasten a decline in creatinine and possibly shorten the duration of renal replacement therapy. The majority of studies have shown that loop diuretics don't have a direct effect on renal functional recovery or the natural history of acute kidney injury, and in fact, may increase operative mortality and delay recovery of renal function. However, loop diuretics have uniformly been shown to improve urine output and can often convert oliguric to non-oliguric renal failure if administered early after the onset of renal failure. This may minimize the adverse impact of fluid retention on pulmonary function. An improvement in urine output suggests that the extent of renal injury is less severe in patients with diuretic-responsive renal failure and may portend an earlier decrease in serum creatinine, contributing to an improvement in short and long-term survival. Furosemide. Furosemide is given in incremental doses starting at 10 mg IV. However, once acute renal failure is established, a dose of 100 mg IV is commonly required and should be given over 20-30 minutes to minimize ototoxicity. If urine output fails to increase with a few hours, the following steps can be taken. Increase the dose of furosemide up to 200 mg IV, limiting the cumulative daily dose to 1 gram. Use a continuous infusion of IV furosemide. Give a loading dose of 40 to 100 mg and then initiate an infusion of 10-20 mg hour. Rebolus before and increase in the infusion rate. This may be the best means of maintaining an adequate urine output. Alternatively, bumetanide can be given either as a bolus dose of 10 mg IV or as a 1 mg load followed by a continuous infusion of 0.5-2 mg hour depending on the estimated creatinine clearance. There is little evidence, however, that one loop diuretic is better than any other. Various combinations of medications may be effective in improving diuresis. Add thiazide diuretics to the loop diuretics. This includes chlorothiazide 500 mg IV, metolazone 5-10 mg per dose or via a nasogastric tube, a hydrochlorothiazide 50-200 mg per dose. Thiazides block distal nephron sites and act synergistically with the loop diuretics to increase exposure of the distal tubules through solute. This combination is particularly effective in patients who tend to be diuretic resistant. The combination of dopamine and furosemide may be synergistic because the renal vasodilation and improved renal blood flow produced by dopamine improve the delivery of furosemide to the loop diuretics to increase exposure. The combination of mannitol 500 ml of 20% osmitrol plus furosemide plus dopamine started within the first 6 hours of oliguria has been shown to produce a significant diuresis with earlier restoration of renal function.